Hello.
Hello.
Yes. Good evening. Can you make me the
Hi, ma'am.
co-host?
One
Yeah,
minute,
yeah,
ma'am.
yeah, yeah.
Wait. Yes, ma'am. I have made you the co-host, ma'am. You can share the screen and start the class, ma'am.
Okay, thank you so much. Hello, students. So in this class, we are going to discuss genitourinary, and this is class 5 of our genitourinary. This is a part of our 90-day university pre-final mastery program. And in this program, we are going to rapidly revise all important topics and volatile facts. In this class, what we're going to do is we're going to discuss a few short answer questions, long answer questions, and case-based questions. Also, a few multiple choice questions. In Auricle, we have recorded classes, live classes, practical sessions, exam modules, as well as hard copy books. And also, the purpose of recorded classes are for flexible learning. In live classes, we discuss in-depth chapter coverage along with interactive learning. There is an express exam module which covers the syllabus in just 20 hours, which consists of previously asked questions and exam papers. There is a one-to-one doubt clearing session as well. Hard copy notes are also available for flexible and timely learning. Question banks are available to solve questions which are from easy to difficulty level, beginner to expert level for Proff, PPG as well as FMGE. These are the subscription plans which are available. So this is the session which we are going to discuss in this class. So first of all, the first topic which we are going to discuss is carcinoma of cervix. Okay, so this can be asked as a case or this can be directly asked for you to discuss carcinoma cervix. What is the etiology? The most important thing is carcinoma cervix is a carcinoma which is caused by an infectious agent. There are very few tumors which are caused by infectious agent, and carcinoma cervix in particular is caused by an infectious agent which is a virus, and the virus is human papilloma virus. And there are specific strains of human papilloma virus which you will have to remember. So human papilloma virus can cause benign diseases as well as it can cause cancers. So human papilloma virus, the benign human papilloma virus causes something known as condyloma or warts. So benign viruses, it can cause condyloma or warts. It is caused by human papilloma virus 6 or human papilloma virus 11. Alright, so there are high risk human papilloma viruses, and these high risk human papilloma viruses are implicated in the etiology of carcinoma of cervix. Okay, so these high risk human papilloma viruses are 16, 18, and 33. So these are the high risk human papilloma viruses which you have to remember. So what are the types of cervical carcinoma? We have squamous cell carcinoma and adenocarcinoma. So which is the most common type of carcinoma? Most common type of carcinoma in the cervix is going to be squamous cell carcinoma. And adenocarcinoma can also occur, but it is less common when compared to squamous cell carcinoma. So both squamous cell carcinoma and adenocarcinoma can be caused by human papilloma viruses. Okay. So how does the tumor spread? We know that the tumor spreads by multiple methods. It can be spread by invasion through direct spread through through expanding through direct areas and lymphatic spread and pelvic nodes. Lymphatic spread to the nearest pelvic nodes. So most commonly, it spreads to the nearest area, nearest tissues like bladder and rectum. Okay, so this is what is there. So we have a case study. This is a case of a 40-year-old with ulceroproliferative growth on cervix. Okay, always remember whenever you have an ulceroproliferative growth, that is a clue that we are dealing with a malignant lesion here. Okay, ulceroproliferative is a clue that there is a malignant lesion. So what is the presentation of this patient? Given the presentation of this patient also, bleeding per vagina. So whenever there is bleeding per vagina, along with an ulceroproliferative growth, that is a sign of a malignant lesion. So in this case, they have asked you to diagnose what is the most probable diagnosis. So since we have particular clues here like bleeding per vagina and ulceroproliferative growth, since we have clues like this, and as I already said, ulceroproliferative growth is suggestive of a malignant lesion here. So the diagnosis would be carcinoma of cervix. Now, the second question which you have been asked is etiopathogenesis. We've already discussed that human papilloma virus is the most important etiologic factor in carcinoma cervix. And what are the strains of HPV which are associated? High risk HPV. What are the high risk HPV? High risk HPV 16, 18, and 33 also, which is less common. So other than that, there are other factors which you have to remember like smoking and immunosuppression. So immunosuppression, it is just logically, if the patient does not have any immunity to counteract an infection, for example, the person is already a transplant recipient, okay, or the patient is already suffering from a HIV infection. So these are some causes of immunosuppression, correct? So in these cases, what will happen? There is no proper immunity to counteract another viral infection, which is HPV. So in that case, these patients are more prone to develop cervical carcinoma. So these are a few etiologic factors for cervical carcinoma. This is one of those carcinomas which can be prevented very well. Like there are very few carcinomas which can be screened properly and prevented. Screening procedures are robust in very few carcinomas. For example, we had discussed breast carcinoma, which had a very good screening procedure. Screening ultrasound and screening mammography was done in breast carcinoma, which led to identification of breast carcinoma early and treatment also early, right? So one of such carcinomas is the carcinoma of cervix. Cervical screening strategies are very robust. For example, screening pap smear can be done. Pap smear is a test where a swab is taken from the area, from the cervix, and it is smeared into a glass slide. Okay, and then it is sent to the laboratory for examination of any atypical cells, any cells which are suspicious of carcinoma. So that is what is done. Another thing which is done in cervical carcinoma is HPV testing. So I said that there are two HPVs which are implicated in the etiology. So we have HPV. If this HPV is detected in blood previously, then these patients can go ahead and develop cervical carcinoma in the later stages. So this is a protocol that we test for HPV, the presence of HPV. So pap smear is one screening test and HPV testing is another screening test. Apart from this, there are vaccinations against human papilloma virus also. So these are a few preventive strategies which are used in carcinoma cervix. Screening tests, pap smear and HPV testing, and also vaccination against human papilloma virus can be done. Human papilloma virus vaccination, as I discussed, prevents infection with high-risk HPV types. There are screening tests like pap smear and HPV testing, which we already discussed. When should the screening start? The screening should start, screening HPV testing along with pap smear. So this is the screening. Usually these are done together, HPV testing and pap smear. So these screening tests should start at the age of 21. Based on, and the frequency is based on what is being done, and if the test is positive or negative, according to that the frequency varies. But remember, the screening tests are started at the age of 21. What is the importance of these tests? It is very simple, right? If we are able to diagnose these cervical carcinoma at early stages, then it is easy to prevent these carcinomas also. So that is the reason. We can detect them early and we can avoid it from spreading, and easy surgical resection, or we can easily cure these patients. So now this is also one question which has been asked. Cervical intraepithelial neoplasia. Whenever you see the word intraepithelial, always think that this is a pre-cancerous lesion. There are two words which you have to remember. One is intraepithelial and another one is in situ lesion. So whenever you see these words intraepithelial and in situ, that means that these lesions are pre-cancerous and these have not yet reached the stage of carcinomas. There are three grades of intraepithelial neoplasia of the cervix. CIN1, cervical intraepithelial neoplasia type 1, type 2 and type 3. As the name says, you can easily remember type 1 is mild dysplasia, 2 is moderate dysplasia and 3 is severe dysplasia. So what will be seen? Atypical squamous cells will be seen. I'll show you an image of this soon. Okay, so management we have to observe. I'll tell you why we have to observe. So we have a low grade squamous intraepithelial lesion. This is synonymous with SIP, right? Cervical intraepithelial lesion, low grade squamous intraepithelial lesion, high grade squamous intraepithelial lesion. These are used interchangeably. So you don't have to worry about these terms. And low grade squamous intraepithelial lesion, usually what happens in low grade intraepithelial lesions is they regress 60% of the times, they regress back to normal. Okay. But 30% of the lesions persist. But all 30% of the lesions do not progress to high grade. Only 10% of the lesions will progress to high grade intraepithelial lesion. Whereas high grade intraepithelial lesions will regress 30% of the times and go back to low grade intraepithelial lesion. But the rest of 60% of the times it will persist, and 10% of the times it's going to go into carcinoma. So this is the significance. So what we have to do, if we find a low grade or a high grade intraepithelial lesion, we are going to follow the patient up. Okay, because there are chances that this lesion is going to get regressed. It might not develop into a carcinoma straight away. So you have to follow the patient up. That is the reason you have to follow up. So this is how these lesions look. This is a normal epidermis, and we know that cervix has the epithelium of cervix is made up of stratified squamous epithelium, and the epithelium is non-keratinizing. Whereas in the epidermis of the skin, it is keratinizing, right? Non-keratinizing stratified squamous epithelium is what the epithelium is made up of. Now, in the cervix, there is an external part of the cervix where we have stratified squamous epithelium, okay? And then when it transforms into the endocervix and becomes a uterus, so we know that cervix is a part of the uterus, right? So we have an ectocervix as well as an endocervix. There is an ectocervix which is lined by stratified squamous epithelium, and then there is an endocervix, which is the internal part of cervix, which ultimately goes ahead and becomes a part of the uterus. So there is an endocervix. The endocervix is lined by columnar epithelium. So there has to be a zone which has from where the squamous epithelium is transitioning into the columnar epithelium. So this zone is known as transitional zone because as the name says, The squamous epithelium is going to transition into the columnar epithelium, and hence the name, as the name says, it is a transitional zone. So this transitional zone is the most common site where cervical neoplasms happen. Okay. So remember, transitional zone is where the cervical neoplasms happen. So this is what we can see. This is a normal stratified squamous epithelium. Nothing is wrong here. But here you can see that there are some cells. Okay, there are some cells here. These cells have more nucleus when compared to these cells. Right, this nucleus is very small on the top, very small nucleus. But here you can see the nucleus is significantly large. And you can see one more thing, that surrounding the nucleus there is an empty space. Okay, and then you have a cytoplasm here. So these are cells which are very frequently observed in HPV infection. Even in benign infections with HPV, you can observe these kind of cells. Cells with darkly stained nucleus, little bit enlarged nucleus, and surrounding the nucleus you can see a clear space. Okay, these cells are known as poilocytes. These poilocytes can be seen here, because you can compare it. This is not so darkly stained nucleus, and this nucleus is darkly stained. Surrounding the nucleus, you can see that there is an empty space, and then the cell cytoplasm is there. So these cells are poilocytes. They are associated with HPV infection. So you can see them in cervical intraepithelial neoplasia also. And this is moderate. You can see even darker cells, and up to the almost up to the end you have these cells, and CIN3 is what is known as full thickness dysplasia. In full thickness dysplasia, you can see almost throughout the epidermis the cells are very large and the cells are very irregular. But if you call it CIN, the basement membrane should always be intact. Like in in situ lesions, the basement membrane will always be intact, and below the basement membrane there will be no tumor cells. Whenever there are tumor cells below the basement membrane, it's going to be cervical carcinoma. So this is about cervical carcinomas. Now we are going to go ahead and discuss another question, okay, which is adenomyosis of the uterus. First of all, let's see the definition. Definition of adenomyosis is the presence of endometrial tissue within the myometrium. Okay, so uterus looks something like this. This is the cervix. Okay, and then this is the cavity. This is the uterine cavity. The cavity of uterus is lined by endometrium. Here is where endometrium is. And surrounding supporting tissue is, this is the myometrium. As the name says, myometrium will have muscles. Myo is muscle, right? And endometrium is going to have glandular structure. Endometrium will have gland, myometrium will have muscles. We know how a gland looks like, right? You have surrounding, you have cells, and then central lumen. So this is what a basic arrangement of gland is. Central you have lumen and surrounding cells. So this is the basic arrangement of a gland. This is how a gland looks. So this is the endometrium and this is the myometrium. But in adenomyosis, what happens? Endometrial tissue is usually restricted to the cavity. But when you find this endometrial tissue somewhere in the myometrium, then it is known as adenomyosis. So what will happen if such a tissue is present? Pain. First of all, you will have pain, because whenever the job of endometrium is, whenever there is menstrual bleeding, the glands are going to proliferate. So in that case, you will have pain, dysmenorrhea, menorrhagia. Dysmenorrhea is painful menstruation. Menorrhagia is increased menstruation. So because of these proliferating glands, what you're going to have is painful and increased menstruation. Thickened uterine wall with small cysts that you're going to see in imaging. Okay, so this is what it looks like in. So you can see here focal adenomyosis, just one is present, few are present. Diffuse adenomyosis, throughout you can see these small endometrial glands. And when it is concentrated into a single focus, like you can see here, this is known as an adenomyoma. This is known as an adenomyoma. You can see the picture here. This is the normal endometrium. This is where the endometrium should be. It is there. But here only smooth muscle should be there, which should be pink. But you can see here there are some blue structures which should not be present normally. But you can see these things here. These are the glands. These are the gland-like structure which I told you. Cells arranged in the periphery like this with a central loop. So you can see these gland-like structures here. These are from the endometrium. They should not be present within the muscle, that is the myometrium. So it is abnormal, and so this is known as adenomyosis. Now let's discuss another question, which is endometriosis. First of all, as always, the definition. Endometriosis is the presence of endometrial tissue outside the uterus. What was adenomyosis? Adenomyosis was the presence of presence of endometrial tissue in the myometrium. Remember adenomyosis. Adeno means gland. Myo is muscle. Presence of gland inside the muscle. Adenomyosis. Endometriosis is presence of the endometrial tissue outside the uterus. It can be anywhere outside the uterus, but most common site, remember, is the ovaries and pelvic peritoneum in the pelvis. Pathologically, you can see cystic lesions usually in the ovary when you do an ultrasound scan, and chocolate cysts can be seen in the ovaries. So what are the symptoms? Symptoms are pelvic pain because ovaries are present in the pelvic area. So whenever there is going to be a menstrual cycle, what is going to happen? These endometrial glands are going to proliferate and bleed. So when they bleed, what is going to happen? You're going to have pain in the pelvic area because that is where these endometrial cysts are present. Okay, this is your uterus, this is your ovaries, and this is the pelvic area. So this is where bleeding is going to happen. When the bleeding is going to happen, usually uterine cavity has an opening, and it usually the material, the blood, it comes out. But whenever bleeding happen inside these cysts, what is going to happen? It's going to stay there and it is going to get oxidized, and the red colored blood is going to become brown color because of oxidation of hemoglobin. And because of this, what happens? A chocolate colored fluid is formed inside the cysts, okay, which is nothing but hemorrhage of the cysts. Because of that, a brownish chocolate colored fluid is formed, and that is known as chocolate cysts, which are present in the ovaries. So symptoms, as we know, pelvic pain and infertility, because we know ovulation is important for fertility. So these are the symptoms. Now here, this is actually an endometriosis which is present in the bowel. Okay, so these are gastric tissue. These are all actually bowel tissue. Okay, the intestinal tissue, and you can see over here that there are some glands which are present. Right, these are endometrial glands. So they're not strictly restricted to ovaries. They can be present anywhere. They can be present in the colon. They can be present in the lungs. They can be present anywhere. This is endometrial tissue. So this is an example of bowel endometriosis. So this shows the pathophysiology. The cause of endometriosis was postulated to be retrograde menstruation. Like the uterus, usually menstruation happens like this, right? But retrograde menstruation was postulated because a few cells from the uterus would go and deposit in the ovary. So this was a postulated theory for endometriosis. So these are the endometriotic chocolate cysts, okay? And these will produce many enzymes, and these can also lead to pain and tissue necrosis. These inflammatory cytokines. So this is the pathophysiology of endometriosis. Now we go ahead and discuss another question, which is leiomyoma. So again, like always, we'll start with the definition: benign smooth muscle tumor of the uterus. Leiomyoma is nothing but benign smooth muscle tumor of the uterus. What are the sites? There are three major types of leiomyoma. Okay, three major types of leiomyoma. First is intramural. Okay. Second is submucosal. Third is subserosal. This is the uterus. Okay. This is the fallopian tube, the endometrium, and this is the myometrium. Okay. So intramural is within the muscle. So you are going to have leiomyoma within the myometrium. So this is intramural. Okay. Submucosal is whenever mucosa, what do you say? Any internal part is mucosal, correct? So you're going to have here within the endometrial cavity. So this is submucosal. Okay. And another type of leiomyoma is going to be present in the serosal aspect. Serosal aspect is wherever this is the serosa. Okay. The end where the uterus or any organ is coming into contact with the cavity, that is a serosa. So you have subserosal in going towards this. So you can see here, this is subserosal, submucosal, endometrial cavity, and then you have intramural within the muscle. So these are most important types of leiomyoma which you have. Okay, intramural, submucosal, and subserosal leiomyoma. Okay, so gross histologic types, there are many histologic types. Okay, but you have to remember that it is benign proliferation of smooth muscle cells within the uterus. Gross and microscopic features I'm going to show you. So this is the microscopic feature. This is nothing but a smooth muscle over here. Okay, these are all smooth muscle cells. You can see how slender they are. Okay, they look almost like this, and they have a nuclei which is almost like this. Okay, so round to oval shaped cells and slender cells. So these are the smooth muscle cells and proliferation of these smooth muscle cells. In gross, you can see a whorled appearance. Okay, they can form a whorled pattern, and in gross, you can see a whorled appearance over here. In this image also, they've depicted this whorled appearance over here, right? So grossly, you will have a whorled pattern, and on microscopy, you're going to see these slender, elongated, spindle-shaped cells which are proliferating. So this is what leiomyoma is, and it is a benign tumor. So there is not going to be any atypia. So no spread, no metastasis, nothing. Now we are going to discuss another question, which is ectopic pregnancy. So definition: pregnancy outside the uterine cavity. Ectopic means something is happening outside. So pregnancy usually occurs inside the uterine cavity. So when pregnancy happens outside the uterine cavity, it is ectopic pregnancy. What are the risk factors? Usually, what is the normal scenario? What happens? So here we have the ovary, right? And here we have the fimbriae of the fallopian tube. So whenever ovulation happens, it goes into the fimbriae of the fallopian tube, and through the fimbriae, it's going to travel and then reach the uterus. So this is what normally happens, and this is where the zygote is formed when sperm is present at the time of ovulation, right? So this is what is going to happen. Sorry, here is where implantation occurs. So from here, the embryo is going to go to the uterus for further development. So this is what is going to happen, right? But imagine there is a block in the fallopian tube over here. Okay, now the sperm has come and then ovulation has occurred, and here the zygote has been formed. But because of some tubal damage, this is not able to go into the uterus for further development. So what happens is the embryo starts developing here, but fallopian tube does not have the uterine smooth muscle architecture, because uterus has the so much of smooth muscles, it's able to expand itself. but that is not present in fallopian tube, and hence what will happen when this embryo starts growing? This is going to rupture. So what is the complication? Tubal rupture and hemorrhage. Okay. Risk factors, tubal damage. So why will tubal damage happen? The most common reason of tubal damage is pelvic inflammatory disease. So whenever there is a pelvic inflammatory disease, usually caused by chlamydia, okay, chlamydia and Neisseria, these cause pelvic inflammatory diseases. Apart from these, in India, the most common cause is also tuberculosis or tuber block. So these are a few causes of pelvic inflammatory diseases. So these can go and block the tube, leading to ectopic pregnancy. Okay, this is what happens. Now we'll see how this ectopic pregnancy looks like. So this is a tube over here. Okay, this has hemorrhage. This red things which you see, these are blood and these are hemorrhage. Here you can see that there is almost a fetal-like structure which is formed inside the tube. Right, so there is a small embryo over here which is formed and there is rupture. So in the tube, you have these things. In early stages, you won't see so much of a development, but you will see these structures. These structures are known as villi. Okay, these are those structures which have been zoomed in. So these structures are villi. You will see villi as well as trophoblasts. Trophoblasts are these structures. These structures are trophoblasts. So usually there are two types of trophoblasts commonly seen. One is mononuclear trophoblasts, which are cytotrophoblasts, and there are these large trophoblasts. These trophoblasts are known as syncytial trophoblasts. These are multinucleated trophoblasts. Okay, these are mononucleated trophoblasts, which are cytotrophoblasts, and these trophoblasts which are multinucleated and they have darkly stained nucleus, they are syncytial trophoblasts. So these are the two types of trophoblasts which are present. Apart from the villi structure, you can see these structures which are also seen in the embryo. So if you see these in the fallopian tube, then it is ectopic pregnancy. Okay, now let's go ahead and discuss another question. We have Brenner's tumor. Brenner's tumor is a type of epithelial. First of all, definition. So it is a type of epithelial tumor. Okay. This epithelial tumor, it can occur both in the ovary as well as in the testis. In both ovary and testis, this Brenner tumor can occur. What is a very characteristic of this Brenner tumor is it resembles nests of transitional epithelium. Okay. Where do you see transitional epithelium? Transitional epithelium, usually you see it in bladder. Okay, from your histology first year anatomy, if you can remember, bladder epithelium has how many layers? Almost 7 to 8 layers. Okay, 7 to 8 layers of epithelium. And then there is a last layer. Okay, why is this important in bladder? Because it has these many layers packed together, it can also expand very well. So that is the very important and crucial feature of transitional epithelium. So similar to bladder epithelium, you will have nests of cells which are present here. These nests. These also you can see has so many layers. Nest-like layers, so many layers over here. Okay. And in the stoma is fibrous. So this is very characteristic of Brenner's tumor. Brenner's tumor can be benign or it can show borderline behavior or it can also be malignant. Okay, so this is often an incidental finding. This Brenner's tumor. So that is for Brenner's tumor. Now we are going to discuss another question which has been asked, and this is Meek syndrome. So this is a named syndrome. You have to remember the triad of Meek syndrome. There is no other simpler way of remembering this. So there is ovarian fibroma, ascites, and pleural effusion. You can remember these two, ascites and pleural effusion, because both of them It's going to be fluid accumulation. Okay. Remember F for fluid accumulation, F for fibroma. So fluid accumulation is there. Fluid accumulation in the lungs, in the pleura. What will you call it? You will call it pleural effusion. Fluid accumulation in the abdominal cavity. What are you going to call it? You're going to call it ascites. So fluid accumulation and ovarian tumor, which is fibroma. Okay, so this is there. But very interesting thing is when once this fibroma is removed, somehow uh, ascites and pleural effusion is going to vanish. So here you can see this is an X-ray which shows pleural effusion. You can see here that this is the cost of phrenic angle. Okay, this is the diaphragm, right? Usually you have something like this proper beak shaped area. Okay, this is the diaphragm and this is the angle. But here you can see that there is blunting over here. Okay, there's a U-shaped area because and there is full of white appearance here. That means this is air which is black and this is fluid which is white. Okay, so this is water filled area over here and this is the pleural effusion. Water has been filled inside the pleura. And similarly, here you can see usually in these areas you must see air, right? So similarly, you can see here that water has been filled compared to this how dark this is, and this was very gray. So this is pleural effusion over here. And when you this is the fibroma, ovarian fibroma, homogeneous appearance. Okay, homogeneous white appearance you will see in fibromas on gross. So whenever fibroma is removed, pleural effusion and ascites is going to vanish. So this is Meek syndrome. Now another question we are going to discuss, which is classification of ovarian sex-cord stromal tumors. Sex-cord stromal tumors are granulosa cell tumor, Sertoli cell tumor, and fibroma. Fibroma we have already discussed. Fibroma has white colored appearance, homogeneous appearance associated with Meek syndrome. Sertoli Leydig cell tumor, as the name says, you just think about it once from your first year histology. Remember, there were Sertoli cells and Leydig cells. Where were these cells present? Mostly they were present in the testis, right? So what are the function of these cells? Sertoli cells and Leydig cells, we know Leydig cells is going to secrete testosterone. Right, and Sertoli cells were supporting cells and they were producing supporting hormones. So in this tumor, you are going to have increased testosterone because it is a tumor of Sertoli and Leydig cells. So if increased testosterone is there in this, and here it is an ovarian tumor, so which means that this patient is a female. So what will happen in case in a female with increased testosterone? You're going to have symptoms like virilization. Okay, you're going to have symptoms like virilization. So this is a tumor where you are going to have increased testosterone and you will have symptoms like virilization. This is just logically you will have these symptoms, nothing else. Okay, granulosa cell tumor we are going to discuss in detail now. So granulosa cell tumor is again a sex-cord stromal tumor. For the definition, we're going to have granulosa cell tumor is a sex-cord stromal tumor of the ovary. Okay, of the ovary, and granulosa cell tumor can also occur in the testis. So now what is this granulosa cells and what do they do? First of all, we know the function of certain dendritic cells. Similarly, there are two types of cells in our ovary. There are these granulosa cells in the ovarian follicle. This is a normal ovarian follicle. Okay, this is a normal follicle. There are granulosa cells and theca cells. So similarly, like Sertoli cells were supporting cells, granulosa cells here are also supporting cells and theca cells are also there. Okay, so this is a normal follicle and these are normal granulosa cells. But when there is a tumor of these granulosa cells, what is going to happen? These small cells, they are going to proliferate. Okay, and they proliferate and they form a rosette-like pattern. We've already discussed what rosette is. Rosette is a collection of cells in this and center lumen. If center lumen is there, then it is a true rosette. And in granulosa cell tumor, you're going to have center eosinophilic material. As you see here, eosinophilic is nothing but pinkish material. So here you can see pinkish material. And look at these granulosa cells. Can you observe something very specific? This cell. Okay, these are granulosa cells. What can you observe? There is a center groove like up. There's a center groove. So there is a center groove which resembles a coffee bean. So hence this is known as a coffee bean nucleus. Coffee bean nucleus. And these structures which form a rosette-like structure and center eosinophil, these are known as Kollexner bodies. Okay, Kollexner bodies. So these are known as Kollexner bodies. Okay, so you can see lots of Kollexner bodies here. These are all Kollexner bodies. Kollexner bodies are very unique to granulosa cell tumor. So what are the key features which you have to remember? Histologically, this is a sex-stromal tumor of the ovary and testis. We know that. And this is proliferation of granulosa cells. We also know that. These are Kollexner bodies. They have coffee bean type nuclei. Okay. And granulosa cells, as we know, part of a ovarian follicle layer. So they produce estrogen. And whenever estrogen is produced, what is the function of estrogen production in menstrual cycle? If you can go, we can go back to our physiology and review the menstrual cycle. You remember that in menstrual cycle, there were 3 phases, right? What were the 3 phases? There was a proliferative phase in the menstrual cycle, proliferative phase, there was a secretory phase, and there was a bleeding phase or the shedding phase. So in proliferative phase, which hormone was increasing? In proliferative phase, estrogen was increasing. Okay, and in secretory phase, which hormone was increasing? Progesterone was increasing, right? And then here was where LH was coming in for ovulation. Okay, and then when progesterone was going down, then bleeding phase was happening. So this is the normal menstrual cycle. So remember, whenever Kollexner bodies are there, granulosa cells are going to get produced in more number and they're going to increase estrogen production. So when estrogen production is more, naturally proliferative phase is going to go high, because if proliferative phase is going to turn into secretory phase, that means estrogen should go down and progesterone should go up, which is not going to happen. So proliferation is going to go on. If proliferation is just going on continuously, then what will happen? If proliferation is just going on continuously, then endometrial hyperplasia will happen. Because proliferation, endometrium is just proliferating and secretory phase is not happening. Estrogen should go down and progesterone should go up for secretory phase to happen and then bleeding to happen. So endometrial hyperplasia is only happening and no bleeding is happening. So you're going to have irregular menstrual cycles as well as you're going to have endometrial hyperplasia. And also remember, endometrial hyperplasia is a very important risk factor for endometrial carcinoma. So indirectly you know the mechanism how endometrial hyperplasia is happening in granulosa cell tumor, and endometrial hyperplasia can also lead to endometrial carcinoma. Okay, so these things can happen. And granulosa cell tumor, this is a very unique feature of granulosa cell tumor. As I said, for sertoli Leydig cell tumor, testosterone was there. For granulosa cell tumor, estrogen is there, which is leading to the pathophysiology. Kollexner bodies also, remember Kollexner bodies, rosette-like bodies, structures with central eosinophilic material, coffee bean type nuclei with central grooving. Okay, this is granulosa cell tumor. And now we are going to discuss another question, which is Trockenberg's tumor. Trockenberg's tumor, the definition is metastatic gastric carcinoma to the ovary. Metastatic, it could be gastric or even colonic carcinoma to the ovary. So whenever a tumor is occurring in the ovary, primary, it is usually unilateral, because it is very unlikely that both the ovaries simultaneously develop a tumor, right? But this is bilateral because it is a metastatic tumor which is occurring, which is metastasizing from the colonic or gastric mucosa, gastric tumor to the ovary. So in this case, this can be bilateral. What is a very important feature of Kuchenberg's is signet ring cells, which are present inside the ovarian stoma. Signet ring cells are those cells which are cells which have nucleus, and this nucleus is pushed towards the periphery. Okay, why are they pushed towards the periphery? Because these are filled with mucin. So this is the signet ring cells. You can see mucin filled cells. Mucin filled cells which have nucleus pushed towards the periphery. These mucin are usually in histopathology purplish in color, light purple blue in color. Okay, so this is signet ring carcinoma or Kuchenberg's tumor. Kuchenberg's tumor, specifically this name is for a signet ring carcinoma which is present in the gastric or the colonic area which metastasizes to the ovary. So the name is specific for that tumor. Now we are going to discuss another question, which is hydatiform mole. So this is a definition is an abnormal pregnancy with trophoblastic proliferation. Okay, this is an abnormal pregnancy with a trophoblastic proliferation. Trophoblasts are, what is trophoblasts? We already discussed. They are cytotrophoblasts and syncytial trophoblasts. Cytotrophoblast was a single nucleated cell, and syncytiotrophoblasts was a multinucleated cells, and these are cells which proliferate during pregnancy, and these produce certain enzymes like HCG. Okay, trophoblasts produce some enzymes like hormones like HCG, and this HCG is going to be high in mole, highlighted form mole. The reason being trophoblastic proliferation. So they're going to produce high amounts of HCG, and because of that, we're going to see high levels of serum HCG. So there are two types of moles, complete mole and partial mole. Okay, so complete mole is usually because of paternal chromosome duplication. Okay, only paternal chromosome is going to be there, no maternal chromosome. So there's going to be only one set of gene, 23X, which is from the father, and there's going to be auto duplication of this maternal chromosome is inactive, and because of this you have this 46XX. But with this 46XX, there is no way to form a viable fetus. So we have this grape-like structures forming, which is known as the complete mole. So imagine we have only paternal chromosome here. So there is no way of forming a viable fetus. So you will not have a viable fetus here. You will have only grape-like structures which are there. Grape-like appearance will be there. No viable fetus is going to be there in a complete mole. Okay. But the case with partial mole, this is complete. This is partial. But the case with partial mole is different. The partial mole is because of dispermy. That is, maternal chromosomes are very much intact, and you have dispermy. You have two sperms fusing. Because of that, you have a triploid fetus, 69XXY, or you have 69XXY. You have a triploid fetus which is forming. And because of this, again, this is also not viable, but you can have fetal material in this. Okay, you can have fetal material in this. So whenever there is a partial fetal material, always think it could be partial mole, because there are a few viable maternal as well as paternal chromosomes here. Okay, there is one more new marker which can distinguish between maternal as well as paternal, that is partial and complete mole, which is P57. We know that in complete mole, It is paternal duplication. So maternal chromosome will not be there. Okay. P57, that is the reason why P57 is negative in complete mole and P57 is positive in partial mole, because P57 detects the maternal part. Okay. So that is the reason P57 can help in distinguishing complete as well as partial. So this is about complete and partial mole. Always remember the mechanism: maternal chromosome inactivation, and also you can see only 46X6 because there is no 46X6 only you will see in complete mole. Okay. And the mechanism, remember, diandry for partial mole and maternal chromosome inactivation and paternal chromosome duplication for complete mole. Okay. So this is some images I've included. Okay. This is a partial mole over here. You can see these large structures are villi. Okay. And these structures which are supporting over here, these are trophoblasts. You can see trophoblasts are not much proliferated here. Okay. And you can see two types of villi. That is, you can see smaller villi, also you can see larger. These are smaller villi, these are larger villi. So if you see smaller villi and larger villi, then it is a partial mole. Okay. But if you see only larger villi, and if you see lots of trophoblast proliferation here, you can see that there's lots of trophoblast proliferation here. Okay, so these larger villi, only larger villi, then that is complete mole. So these are a few clues to remember. Okay, now I'll just review this once. Okay, complete mole, paternal duplication, partial mole, diandry. If you see fetal particles, then it is partial mole, not complete mole. P57 positive, partial mole. P57 negative, complete mole. So these are a few features which you have to remember, and with this you can make a table, complete mole and partial mole, and then you can write the features also in your exam. And you can write a few histologic features also. Two types of villi: partial mole, small and large villi, partial mole; trophoblast proliferation, only large villi, complete mole. Okay. Now, in this context, Porocarcinoma. Porocarcinoma is a malignant trophoblastic tumor. Those were benign conditions. Now, this is a malignant condition. So, this is a malignant trophoblastic tumor. This is the definition. And this is a very aggressive carcinoma. And it directly spreads via blood and reaches the lungs. Most common site of metastasis in choriocarcinoma is lungs. High levels of HCG, very logical, because trophoblastic tumor, trophoblast is going to produce HCG, high levels of HCG in choriocarcinoma. Treatment is chemotherapy. Remember, this is one tumor where you can give chemotherapy and actually see some results. So, you can give methotrexate as a chemotherapeutic agent in choriocarcinoma. Okay, and so I have included an image over here. So look at how bad these cells look. Extremely bad, large. Okay, very these are all mitosis. So this is what you can see. Lots of some multinucleated cells also you can see here. Some cells have multiple dark nucleus. So these are syncytial trophoblasts. And single nucleated cells are cytotrophoblasts. So remember, this is very rapidly spreading tumor, and on gross examination you are going to have lots of necrosis and lots of hemorrhage in this tumor. Okay, this is a very bad looking tumor also. You see something like this, extremely dark and very bad looking, this could be choriocarcinoma. You can see these cells, right? This is a single cell only, but you can see how many nucleus these cells have. See this one? Again, multiple nucleus. So these are what syncytial? These are all syncytial trophoblasts. And this cells with single nucleus, these are all cytotrophoblast. So these proliferation is happening. This is choriocarcinoma. Okay, now we're done with most of the topics. We'll discuss a few cases and then we'll wind up the class. The first case is a 48-year-old woman who presents with abnormal vaginal bleeding and postcoital spotting. Okay. On examination, there is an ulceroproliferative growth on the cervix that bleeds on touch. Very typical of cervical carcinoma. And they have given us that squamous cell carcinoma is also confirmed. So what is the causative agent? Okay. So we have options over here. This is a very easy question. We know the answer is high risk HPV infection. Okay. So they have other options also. I think most of the options, BRCA1 mutation, prolonged use of oral contraceptives, these are all risk factors for breast carcinoma and not cervical carcinoma. Okay. And then we have which screening test is recommended for early detection. So we already discussed screening tests. We had pap smear, which was a screening tool for detection. And then we also had HPV testing. So these two were screening tests. So we do not have HPV testing, but we have pap smear here. So this is the correct answer. Colonoscopy is also a screening test and it is used to detect colonic carcinoma, colon carcinoma. Carcinoma CA125 is also an important screening test and it is used to detect carcinoma of ovary. Though not very specific, but it can be used in some cases. Mammography for breast carcinoma. Okay. So the next question. A 36-year-old woman presents with severe dysmenorrhea. She has menorrhagia and pelvic pain. On imaging, we can see that the uterine wall is thickened with small cysts. Her symptoms have progressively worsened over the few weeks. So, this person has dysmenorrhea, menorrhagia, and pelvic pain. Okay, imaging has been done, and uterine wall shows a few cysts, right? So that means there is something present within the myometrium. Okay, so that is why it's showing a few cysts. What is the condition where endometrial tissue was present inside the myometrium? This was known as adenomyosis, right? From our discussion today. What is the histologic finding which is present? Again, very easy. Presence of endometrial glands within the myometrium. Correct. Now, let's discuss the other options. World pattern of smooth muscle bundles will be seen in leiomyoma. Is this leiomyoma? No, because leiomyoma will not have cysts. Trophoblastic invasion inside the fallopian tube is ectopic pregnancy. We saw in the fallopian tube, we had trophoblastic invasion. We saw an image also. So this is ectopic pregnancy. Molecular bodies are seen in which condition? Granulosa cell tumor. So everything we have discussed today. The third question, a 28-year-old woman presents with acute abdominal pain and a missed menstrual period. Okay, she has a missed menstrual period. She has a history of pelvic inflammatory disease. Pelvic inflammatory disease also she has. An ultrasound shows an adnexal mass but no intrauterine pregnancy. So again, this is very classic. The patient has a history of pelvic inflammatory disease which might have led to tubal block. Okay, because of tubal block, she must have developed an ectopic pregnancy because there's a history of missed menstrual period also. So this is a classic history of ectopic pregnancy. What is the complication? We also know complication is tubal rupture and hemorrhage. We also discussed this. Okay. Now the last case, a 45-year-old woman presents with abdominal bloating, pelvic pain and irregular menstrual bleeding. An ultrasound shows a solid, well-defined ovarian mass. Histology reveals small round cells arranged in microfollicular pattern with eosinophilic rosette-like structures. What are these structures called now? Microfollicular pattern. We know the microfollicular pattern with central eosinophilic rosette-like structure. These structures are nothing but call-external bodies. They have given a very good clue. So which tumor do we see call-external bodies? Granulosa cell tumor. What is the most common histologic feature in this condition? Call-external body. So very easy. Chocolate cysts with hemocentrin-laden macrophages. Endometriosis. Okay, chocolate cysts with hemosiderin-laden macrophages seen in endometriosis. World pattern of smooth muscle seen in which condition? It is a uterine tumor. Or which tumor? Leiomyoma. Okay. Next one, signet ring cells. Again, ovarian tumor. Metastasis from GIT Ruckenberg tumor. Okay, so in ovary, if you see chocolate cyst, then it is endometriosis. This is leiomyoma and Ruckenberg tumor. So that's it for today's class. Thank you so much.